right. Welcome back to another episode of Palm Peeps. We've got a good rapid fire journal club for you today, continuing our summer series on landmark trials and ARDS. Today with me, as always, is Dave Ferfaro. Hey, Dave, how are you?
Good. Hey, everybody. Love to be back doing this, talking about actually one of my truly favorite trials today. So, as excited as I've always been about ARDS during the summer, today I've really been looking forward to.
Today, we're going to be talking about one of Dave's favorite trials, which is definitely not the reason we picked it, but it is, in fact, a really landmark trial in and of its own, beyond our editorial biases. So, this is PROSEVA, a trial of proning. This was published in the New England Journal in 2013.
Absolutely. And yeah, prone positioning I think is so cool. I think the trial is cool. I also think the physiology is cool. So, as you are on the beach this summer in the prone position on your lounge, I want you to think about why your chest and lung compliance is different than when you were supine. So, Luke, tell us about the background before this study. What did we know and what didn't we know?
Yeah, so previous studies had shown improvements in oxygenation and possible reductions in ventilator induced lung injury with proning, but had not shown mortality benefits. At the same time, meta analyses suggested that there might be a survival benefit in severely hypoxemic patients.
Yeah, thanks, Luke. There had been some interest in this topic for quite some time. I think dating back into the 70s is the first time it really came up. From my recollection, prone position was initially discovered by a bedside nurse treating pediatric patients. And there was immediately some benefit to these patients in their oxygenation. And since then, there have been a number of sort of small studies and then meta-analyses, as you were pointing out, to try to analyze if this is going to be helpful for people with lung injury. So great that we have a study that gives us a definitive answer. So what is the design? Who are the patients? And what are the outcomes of interest?
Yeah, so in terms of design, this was a randomized controlled trial in 27 mostly French ICUs that were all already experienced in proning that ran from January of 2008 to the summer of 2011. In terms of outcomes, their primary outcome was 28-day mortality, and then secondary outcomes were 90-day mortality, vent-free days at 28 days, and then ICU length of stay. Interestingly, just in terms of definitions, they only counted something as a successful extubation if there was no reintubation or positive pressure use, so non-invasive ventilation use in the first 48 hours after extubation, which is just an interesting kind of note on the side that I guess someone you would extubate to BiPAP technically wouldn't have been counted as a successful extubation in this paper.
Oh, that is interesting. I don't know if I ever realized that like that nuanced point about it. I do like that they have sustained extubation, but I hadn't thought about the non-invasive. I'll have to go back and look at the supplement a little. I also just wanted to point out that this is the trend in the right direction and the modern direction in critical care literature of looking at primarily clinical outcomes of most significant interest. So here we have 28-day mortality, obviously a great outcome and one we're really interested in. And then we're also looking at 90-day mortality. And then I think there's even been a shift more to a lot of critical care trials today having 90-day mortality as their primary outcome to say, look, this is the most meaningful clinical parameter for an intervention that could reasonably be expected to impact it that we should be studying. Great. So what are the inclusion and exclusion and what do these patients end up looking like?
Yeah, so in terms of inclusion criteria, this was anyone with ARDS for less than 36 hours, with a P to F of under 150, with an FiO2 of at least 60% after a 12-hour stabilization period, and they had to be receiving low tidal volume ventilation. In terms of exclusion criteria, there were a handful. So anyone with an intracranial pressure over 30 or a cerebral perfusion pressure under 60, massive hemoptysis, anyone with recent tracheal surgery, sternotomy, a fresh pacemaker, or an untreated DVT, anyone with unstable pelvic, femur, or spine fractures, pregnancy, anyone on ECMO or getting inhaled pulmonary vasodilators, folks who'd had a lung transplant or had chronic respiratory failure. And then the last two, folks with more than 20% total body surface area burns or who had had more than 24 hours of non-invasive ventilation before randomization. Generally speaking, they're looking to exclude folks who it would be dangerous to prone or who had been sicker longer maybe than you would anticipate with that more than 24 hours of non-invasive ventilation. And so, in summary, who they enrolled were early, severe, overweight ARDS patients that were requiring advanced support. And what I mean by that advanced support is that the mean PDF here was 100 at randomization. The mean BMI was about 29, and more than 80% of the patients were paralyzed, with more than 70% of them on pressors. There was a slight difference in the two groups. So the supine group had a slightly higher rate, around 83% of pressor use, than the proning group did. But in general, these were sick patients.
Yeah, well stated, Luke. I think if you're listening to our summer series on ARDS, you've been following who these patients are, and we've been talking about mean P to F. Mean P to F of 100 means we have a very sick group. We have some patients who are really in severe ARDS, and then, as you point out, high rates of requiring neuromuscular blockade and of concomitant shock. So, a sick group of patients. The one thing that I will also point out here, and I don't want to go on too much of a tangent, but is that they excluded patients with inhaled pulmonary vasodilator use. And I think this is just an important thing to note because a lot of trials of severe hypoxemia and ARDS, for example, ECMO trials, will allow this now. As we've seen in a bunch of studies, and maybe we'll dive into them one day, inhaled pulmonary vasodilators will increase your oxygenation, but don't have a sustained or known impact on mortality. And so in this study, I think it's important that they excluded those patients because it could influence your practice. If you see someone with a mean PDF of 100 who's in shock and you're trying to decide what to do next, and you had proning or inhaled pulmonary vasodilators, you really have an answer with this trial of what the benefit or harm, and we'll take a look in a second, would be based on what your decision is. All right, so we have our setup of patients. Luke, why don't you tell us what interventions they were going to look at? The devil's in the details. How are they going to manage these patients in the prone strategy and in the supine strategy?
Yeah, so there were 466 patients that were stratified by ICU and then randomized to either proning or not proning. And so in the proning group, the way the intervention worked was you got proned within 1 hour of randomization for a session of at least 16 hours straight. You were allowed to then supinate someone, and you continued to reprone them until either one, you reached day 28, which was just the end of the study. Two, you got better, so your P to F was 150 or higher, and then they had requirements for a PEEP of 10 or less, and FiO2 of 60% or less. That was at least 4 hours after supinating, so you couldn't prone someone, make the numbers pretty, flip them back over, and then stop proning them. You stopped proning if they got worse with proning, which makes sense. And then similarly, if there was some life-threatening complication of proning, so if they were accidentally extubated, if they developed massive hemoptysis, if their ET tube got obstructed when they were proned, like that. And then for everybody, there was kind of standardized ventilator management. So everyone got a tidal volume of 6 cc's per kilo ideal body weight in volume control with a square wave form for flow. PEEP was titrated per table, and they were aiming for plateau pressures of 30 or less and a pH of 7.2 to 7.45.
Great. So, and that's an important point at the end is that they were really doing optimal ARDS vent management for all of these patients. Two of the nuances I'll just point out here is that there are a couple things about the continuing proning. One is that they said they would stop proning if they got worse with proning, but there's no statement in this paper that says if you don't see a significant improvement in P to F ratio or in compliance with your first proning trial that you don't keep doing it. And so I think this is important to remember for our patients that we're proning. We all love to see numbers look better right away. But if those numbers didn't get worse, we wouldn't have stopped according to the PROSEVA trial. And then second, they did this up until 28 days. And so people could be flipped back and forth for 28 days as long as they didn't meet these criteria. And I think that's another important thing to remember. We'll talk about how many sessions they generally did receive. But if a patient goes prone, maybe some patients will get better right away and everyone feels really good about the intervention. Maybe they don't have a huge improvement, but they don't get worse. And then you flip them again. And there's often a discussion like, should we go through the trouble of proning them? And just as a reminder from the protocol you just read us, is that the answer would be yes, right? This is the trial tells us pretty clearly how we keep doing this. All right. So then we have this protocol. Luke, what did the patients end up receiving and what did the outcomes end up showing?
Yeah. So talking about outcomes and then dose and kind of safety, I think it's interesting just to point out how ambitious the folks designing the trial were. So when you look at their power calculation with a sample size of like 456, which is slightly less than what they ended up enrolling, they had a 90% power to detect a 15% mortality benefit based on estimating that the control group would have a 60% mortality, which is really high, but like not that far off from what we actually see in, like retrospective reviews of patients with this severe ARDS. So just kind of underlying how sick these people are. In terms of what they achieved, so in terms of a dose, the averaged 4 sessions per patient for a mean of 17 hours at a time that represented 73% of all those patients' ICU time, which is really impressive. In terms of mortality, this was a floridly positive trial, just to cut to the chase. So at 28 days, mortality in the proning arm was 16% versus 32.8%. At 90 days, it was 23.6% in the proning arm versus 41% in the control arm. That is a massive, like 16.8% absolute reduction of mortality at 28 days, which gives you a number needed to treat of just 6, which is like one of the most effective things that we have in critical care medicine. In terms of event-free days and their kind of secondary outcomes, those also tended to favor proning, as you would expect. So there were about 4 more event-free days in the proning arm, 14 versus 10. And then ICU length of stay, interestingly, was 24 days versus 26 days. So a little less impressive, but still seemed to favor the proning arm. That had a p-value of right at 0.05. Interestingly, too, for that ICU length of stay, that was specifically the ICU length of stay for survivors. They also reported the ICU length of stay for non-survivors, which is an interesting thing that we won't get into for the sake of time.
Right. Yeah. Shorter stay if you're not surviving to the end of it potentially. Yeah, this is a floridly positive study. I don't think it gets more positive. Part of the reason I like it so much is that it's this really it's intensive, labor intensive intervention in that you need to be safe. You need to have people around who know how to do it. But it's really simple, right? You're not giving a medication. You're really just changing the positioning, and you have this huge benefit. And so, interestingly, pre-COVID, there were still a lot of units in the United States, even at pretty advanced academic medical centers, that weren't doing proning. And there's a couple reasons behind that. A lot of it is logistics. Some of it is people looking at the data in a different way. But I think that this trial could not be more positive in showing you that you have this huge mortality benefit, number needed to treat of 6, a trend in directions of positive effects in all the patients, very limited adverse effects if you were well trained in doing the proning. And so this is just a massive benefit that we can give our ARDS patients. I do think, Luke, we'd be remiss if we didn't talk a little bit about proning because it's such an interesting intervention. So, you're a rising palm fellow now. Your intern is in here in July right now asking you, why does this work? Why does this have any impact on these patients? So, yeah, why don't you take us through it?
Yeah, I feel like that is a question I get asked a lot. Like, why am I being so insistent that someone gets some tummy time when they're this sick in the ICU? And there's a couple of like physiological reasons for why this may work. I think the first is that you get a more uniform lung compliance, and so you theoretically decrease the amount of ventilator-induced lung injury. That mostly happens from improvements in the distortion of the lung that's caused by shape matching, which is a fancy way of saying if you take the lung outside of the chest, it is not the same shape as your chest cavity. And so parts of the lung are kind of stretched or squished normally just to fit into your chest cavity. And when you prone someone, that plus different effects of gravity from being in a different position make the lung a little more uniform, which helps kind of decrease some of that stretch induced lung injury. You get improvement in the posterior lung zones with proning, and incidentally, most of the lung is posterior. And so that kind of helps explain why this may be beneficial too. And then it wouldn't be a journal club discussion with me and Dave if we didn't talk about PVR and hemodynamics a little bit. So this improvement in your lung compliance also theoretically could lead to some decreased PVR or pulmonary vascular resistance, which can offload the RV. When again, if you remember that most folks with ARDS are not dying because of hypoxemia, they're dying because of other organ failure. Knock-on effects onto your hemodynamics and your circulatory system could be beneficial as well.
Very well said, Luke. I think really interesting physiology. And so if we can post some pictures along with this episode to sort of show some of this improvement in uniform lung compliance, especially in the posterior lung zones as well. And then I'll just add one thing that is still a little bit of a question in the proname world is that in this trial, they really followed a protocol of 16 hours, as you pointed out, it was a mean of 17 hours, and then supinated again. As we've done proname more, there are places that would do longer sessions of proname, 24, even 48 hours, sort of just keeping people there, especially if they desaturate when they go back in this supine position. And I guess I'll just say is that there is some discussion of redistribution of non-cardiogenic pulmonary edema and getting variable recruitment of areas of the lung. And so there may be something to the going back and forth. And it hasn't been studied yet of prolonged proname versus proname with supination. And I think it's still a question that I don't know the answer to, but just sort of pointing out what they did in the protocol. All right. So what's the takeaway? What's the one-liner that people should remember from this trial, Luke?
Yeah. So what I would say for the takeaway for me here is that early prolonged periods of proning in ARDS patients with a P to F under 150, despite optimization and stabilization, saves lives and speeds liberation from the ventilator and the ICU.
100%. That's the takeaway for me too. Love PROSEVA. We should always be thinking about proning in these sick ARDS patients. It's probably the most beneficial intervention we can do aside from low tidal volume ventilation in trying to protect them and get them to be better and survive this very severe illness. Okay, thanks everyone for listening in again. We'll see you for our next episode and hope you're enjoying your summer. Thanks, Luke.
Thanks, Dave.